I'd like to welcome everybody to Grand Rounds today. Dr. Roman's in the air right now, so he'll be tired when he gets back. Our topic today is complications of cirrhosis, and this is a very important issue. Liver disease is continuing to rise in the United States. That alcoholic liver disease remains a major problem. I think we just heard on TV that they're going to screen all baby boomers like myself for hepatitis C, so we expect 1 million new diagnoses of hepatitis C in the next 2 years. And 1 out of 3 Americans has fatty liver disease, so this is a huge problem. And Dr. Neff and I just came back from Digestive Disease Week, where we heard more about what the government's going to do with health care, the Obama health plan, and it's clear they're going to be looking more carefully at rehospitalizations, costs of care, and ways of more effectively delivering care and quality outcomes. And they're going to be especially focusing on cirrhosis as one of their diseases of interest. So it's a great topic, and we have a great speaker, Dr. Guy Neff. Guy did his training in the University of Miami with Gene Schiff, the same place that Luis Marzano trained. Guy was head of Transplant Hepatology at Cincinnati, basically built the program there, and he was to Cincinnati what Dr. Marzano is to Louisville. Critically important. We were pleased that he left because that's allowed a lot of patients to come from Cincinnati down to Louisville. Guy is now director of transplant hepatology at Tampa General, and to show how important Guy is, Tampa General now does over 100 transplants a year, so he's really revitalized that program. So Tampa General is doing more transplants than the University of Pittsburgh this last year. So welcome, Guy, and he's going to again talk about complications of cirrhosis.
Thanks. Well, I appreciate the introduction, and it's nice that I don't have to move the mic. That'll work perfect. You know, it's gotten to be such a common problem that I was kidding Craig earlier, is that the gentleman that picked me up in the cab at the hotel this morning actually knew right where the hospital was because he has NASH. So we're seeing so much liver disease. But just a quick history about myself. I was, as Craig mentioned, I was in Miami when, what I always say, that's even where the dogs get arrested. So just a quick disclaimer, I do a lot of work in endocrine, nutrition, and physical therapy type of things with cirrhotic patients, and that's where my interest is. That's where it all comes into play with a large number of these companies. The discussion I have is a little bit different because it challenges what we were taught, especially myself, what I was taught as a fellow. And it brings into an area of a few of these areas, and I'm just going to touch the surface of this today. And again, I appreciate your attention and coming early in the morning to hear this, and I hope not to induce any encephalopathy while I do this. But nonetheless, the disease background we know is very common, and we see this in at least 8 million individuals. And why I say that is that this is chronic liver disease is all too common issue. Craig had just mentioned 1 in 3 Americans with fatty liver. We're seeing at least 4 million with hepatitis C, hepatitis B. We're looking at about 1 million. And then you throw in the alcoholic liver disease related issues. So you can start to see that number quickly gets above 10 million. And what we do know right now, at least, is that the most common reason for liver transplantation is hepatitis C. That's probably going to go up even with this new proposal to start testing all the baby boomers. But at the same time, what is felt and believed is that by 2020 that NAF will take over that. I worry about that, and I wonder about that, because I remember in the 90s when we were transplanting patients, we would see someone with a BMI over 40 about once a month, maybe every 6 weeks, that type of thing. It's not uncommon now in any week when we present 10 to 12 patients to be listed that 2 or 3 of them have a body mass index over 40. And why I say 40 is that tends to be the cutoff. At most places, some places 35 for a body mass index. And is that a good indicator for liver transplantation or not? These are all going to come to the forefront in the near future. Now, what we know about cirrhosis is that there's at least 600,000 in the U.S. And what really that number has escalated to close to about 1 million is what the estimation is. So approximately 1 to 100 of your patients to 1 to 150 of your patients that you're seeing each day are probably going to have this type of a problem of cirrhosis. And as you can see, why that comes up is with all the chronic liver diseases we just mentioned. The number of cases of hepatic encephalopathy, which is a common problem related to cirrhosis, continues to escalate, especially as you can see here over the past 10 years, and even if we go back to 2002, that number has gone up to now where we're expecting it to be over 400,000 a year, cases of hepatic encephalopathy. And that's not necessarily the cases that continue to get readmitted, as we all see too often. Now, the cost of this is going up, and that's where I spend a little bit of my time in pharmacoeconomics, and what Dr. McLean was talking about is that with the healthcare plan that is coming is the bundled reimbursements. And this is going to be the challenge in liver transplantation. That is, if you have a patient that is readmitted frequently before the liver transplant and you're getting one bundled reimbursement for that liver transplant, they're going to price themselves out of liver transplantation. We know in the U.S. right now that there's no one doing free transplants. You know, we did it in the 90s. It just doesn't exist now. One of the reasons we could get away with it in the 90s is that we all had closets full of samples, and the samples have gone away. And I remember in Miami we had, as Dr. Marciano can attest to, is that we had a room that was almost full of patient-donated Prograft. We used to have patients that would bring in their medicines when their loved one passed away, and we'd be able to pass that on or use it in with discretion, obviously. We can't do that anymore. So if a patient cannot afford to go through this process, it's a game changer. And why this is such a big deal is that now a simple hospitalization is averaging about $40,000 per admission for these HE events. So you can see if your hospital per transplant is getting, say, $200,000 to $250,000 for that reimbursement for taking care of a patient 90 days before and 90 days after the transplant, and you've had 2 or 3 HE admissions, they're probably going to process themselves out of that. Now, readmission is a big deal with hepatic encephalopathy and cirrhosis. This is a group at Michigan, Dr. Bolt, that recently showed this. And one of the things that I've always stated about this is I wish they would have taken it to the next step, and that is, how do you prevent these readmissions? And that's where most of us are right now. This is what we all see is that these folks tend to come into the hospital, and as they've progressed through cirrhosis, and keep in mind that in cirrhosis you have an early stage where these are sometimes people that are hard to identify. You have the middle stage where we start to work up for liver transplantation, and then the late stage, which is where they receive the liver transplantation. That's what they tended to look at here. And obviously these folks create a snowball type of effect that once they have one of these HE admissions, they're often back into the hospital. And you can see the readmit rate was 1 in 3 within a month. So many of these folks, depending upon where they're getting transplanted and what their score is, it can take anywhere from 6 to 12 months to get a liver transplant. So you can see the readmission can be very quick for these individuals. Now, the complications with ascites are many. We tend to focus, and what we'll focus on mostly today will be the hepatic encephalopathy, but also the parts that play into it, not just with the disease causing the problems, but what we do to the patients. And that's what I mentioned early on, is some of the things that we were taught are starting to come into question. And as you can see here, what I've always been impressed with is, yes, SVP, hepatorenal syndrome, hepatic hydrothorax, these are problems that we all worry about. But when you look at varices and the variceal hemorrhage and the risk of mortality, it's a little bit lower now. We're even getting less than 30%. We've done such a good job with the banding, octreotide, et cetera, and managing these patients with antibiotics, trying to prevent the rebleed. But when you look at hepatic encephalopathy, when they have that first event, their survival is markedly decreased. It's actually less than 50% at 1 year. And if you look at this slide, this is, it's not exactly, but it's very comparable. I remember from the late 80s looking at what cardiology was looking at with the myocardial infarctions, is that when folks came in, before caths came in, so to speak, that you would see a marked decrease in survival in that first year. Well, at the time, and I remember, and I wholeheartedly agree with the cardiologists, is that they felt that Lipitor or some type of anti-cholesterol medicine ought to be in the public water. And for the most part, what you've been able to see is a marked improvement in that, in their preventative measures. And what I mean by that is, in hepatology at least, what we tend to do is treat these problems after they've occurred. And what you're seeing is a paradigm shift in hepatology, where we're starting to try and treat these individuals as we make the diagnosis of cirrhosis, or even earlier, and hopefully try and prevent some of these problems, prevent this patient from going down this road and improving their survival. Because once they have a hepatic encephalopathy event and are in the hospital for that, the avert event, you can see that they're discharged. And I know that the folks here, that this is the HCUP data from the government, but it's not so routine. If you have a toddler, these patients become toddlers, is what I would say. They need to be watched 24/7. They do a number of things, and I'm sure if we went around the room with the various gastroenterologists, hepatologists, and talked about what crazy things that our patients have done that have had an overt event of hepatic encephalopathy, we all come to realize that these folks are not routinely discharged. And an example of that is, I had a patient before I left Cincinnati that was riding his Harley to come see me and took on a semi and died 2 days later. Well, his family thought that when I told them that he should not be driving or operating machinery, that didn't mean riding a motorcycle. So, these folks, again, we have to watch very closely. So now, does this just affect the patient? No, this affects the entire family. And this is where the numbers start to crunch. And what I mean by that is that a family member has to change their lifestyle. Just like when you have a newborn, you bring it home, everybody in the house, their whole situation changes. And for some families, that can be crippling financially. And remember, if you have a patient that's on the list, that's gone through the whole process, and they lose their insurance, they become a non-transplant patient now today. It's very different than it was 10 years ago. So just to go over, we talked about how complicated it is for these patients. But what do we do, and what can we do better to help improve the survival of these folks? Well, caregiver issues. Well, there's a number of these things. And how do we manage these? And what I would say is, for me, it's evolved over the last 10 to 15 years. Once I started to recognize the number of these problems, and the endocrine problems are multifactorial. And I don't have the adrenal insufficiencies up there, but those are a large number of problems as well. The daily health issues, the muscle wasting that these patients go through, it's all in a different level. And then you get into all the other organ-related problems. And it brings up the issue that nearly all of our patients have, is fatigue. Because when you talk to a cirrhotic and ask them why they went to see their doctor to begin with, well, they didn't feel well, they were tired. And then you start to talk to the family about what's going on. Well, there's less activity, et cetera, et cetera. You can see all of this starting to interplay. Well, Does this affect their quality of life? Obviously it does, and this has been very well studied, especially in PBC and chronic hepatitis C. Any chronic disease, a patient is going to have some level of mental health dysfunction, such as depression or anxiety or a combination. So it is a major problem. This is a patient that's all too familiar. I know we one of Dr. McLean's old patients, right? Is that correct? That was made famous in New England Journal. Is that where he showed up? Yeah. But what it does is it emphasizes for us they have to be able to pass the test that when you look at a patient, and what I always say to the fellows and medical students and residents when they spend in the first month, I say, if you look at this guy and at the end of the month and when we see these patients and you don't recognize that he has cirrhosis and that he's probably beyond liver transplantation, I did a pretty bad job. So, because obviously when you start to see bones, this guy's lost a lot of muscle that he cannot afford to lose. Well, what do we do as caregivers? And some of these issues are really starting to come to the forefront. For instance, this is a gentleman that all of us would probably do an endoscopy to look and see if he has varices, to try and potentially prevent that first bleed. And I say that, so what we tend to do is this is an individual that's got fatigue, so we put him on a beta blocker. So we have someone that has trouble getting out of bed in the morning that we just put on a beta blocker. Well, about 5 years ago, at the plenary sessions for the AASLD, they asked in a room of about 400 of us who was doing prophylactic banding. And about 5 of us raised our hands, and me being, I probably wasn't paying attention enough, but ended up raising my hand, and we got blasted for this. And what we're finding out now at the most recent AASLD, when they ask that question, it's about half the room. And we're seeing that, but most folks are trying to do it to prevent the bleed. My concern is more of the fatigue management, the stoppage of the sarcopenia or the muscle wasting that these folks go through. I want these patients active. And I remember Gene Schiff, my old mentor in Miami, always used to say, is that it's a bit of a beauty pageant. When you walk in with your transplant surgery team and your patient is intubated and has 5-6 lines in, which patient are they going to do, this one or the patient that you just instructed to have their hair brushed, to shave, if it's a female, put their makeup on? It's a big deal. You want these patients looking good, ready to go. And it's important that these folks do not walk into our clinics or actually walk into our clinics and do not come in a wheelchair. These types of things. These are very important points, is that they have to be able to walk, talk, and eat, is what I always tell them. Now, the second thing that we do, and the dermatologists in the crowd will understand this a lot more than I will, but I was having dinner with my wife about 4 or 5 years ago, and we were talking about polycystic ovarian syndrome and why they use aldactone. Well, that's to block the androgen receptor, basically, in hirsutism. This is also a medicine that is used in transgender replacement surgery. So what it does is it blocks the androgen receptor. So what we've done in this patient, this is a commonly used medicine that we use for ascites management. So what we've done is we've given someone a beta blocker who's already suffering from fatigue, and now we're blocking their muscle receptors as well. And we see this as well, all too common, as a low-protein diet. We still see this from amazing enough, is from some dietitians and some of our transfer patients will send a patient in a protein-restricted diet. Protein is gas to the body. What I always say is that Arnold Schwarzenegger did not win all the Mr. Olympias driving through the McDonald's drive-through and loading up on carbs and fat. So, but we can continue down the list, et cetera, all these things that we have. Hormonal issues. We'll spend a short amount of time on how important it is to try and correct these and stop this muscle wasting, getting these folks active. And as we know, we've seen, we've witnessed these patients go through the transplant process and have a hastened recovery because of it. The mental health issues as well, and some of the things that our patients do to themselves as well. One of them on there, obviously not much that they can do with, is the aging process. Now, the endocrine issues in hypogonadism and sarcopenia are multifactorial. We know that male menopause has hit the forefront recently, And typically that has been age-related, but also in our spectrum, we see a significant amount of it, greater than 90%, I would say, in our cirrhotic patient population. But weightlessness is very important. And what you want is your patient to look more like this guy on the left. And the reason I state that is you can see the muscle recovery. You're going to want these patients when reimbursements get to where it's one reimbursement with the new healthcare plan, you're going to want these patients out of the hospital. And I know talking to our hospitalists, a couple of measures where they're going to be looked at as readmissions and length of stay. And that's going to be a very important issue for all of us as they come through. So can we do more as these patients are getting into the end-stage liver disease process? And I certainly believe that we can. Well, this is such a big deal that it's important in NASA, actually, and that we know that we have the rockets and the fuel to be able to get to Mars. It's a problem of coming back. And what's been stated even at NASA is that they have a 30-year-old that by the time he goes through 2 to 3 months of weightlessness, he may equate to a 70 to 80-year-old body and not be able to make it back. So that's an important issue. And how do we know that is from the Soviets from the late 60s and early 70s that spent a short amount of time, relatively speaking, out in space, where the cosmonauts spent 24 days, could not repair an exhaust valve that should take only about 5 minutes to repair, and the ship disintegrated on re-entry. So weightlessness is a big deal. We see that a lot in our patients, and you heard what I said earlier, is that we tend to do some of these things to the patient along this road that they travel towards death and dying. Now, what kind of data is out there? This is Mike Charlton's work. This is the old pass the eyeball test. The patient that's lost a lot of muscle going into transplant obviously has a multifold increase in post-transplant mortality. We know that. We know the gentleman that was on the right is not going to do as well as the person on the left. And why is that? Well, catabolism is felt to be a very important issue, and I know Dr. McLean and colleagues here have done some work in this, and this has brought in a new era of what we're doing now with these protein drinks at night, and why this is so important. And just to bring this up in a nutshell, this has been studied and looked at for about the last 25 to 30 years in animals and humans. And I had a partner in Cincinnati that actually spent some time in the 80s looking at this. And basically what they're saying here is that the cirrhotic patient goes into catabolism much quicker than the non-cirrhotic patient. It takes them about 8 to 10 hours. And if you were like me as a fellow, we were taught to load these folks up with lactulose at bedtime so that when they woke up in the morning, they were very clear. Well, you actually want to load them up with something like protein, a protein drink of some sort, or something in their stomach so they do not get into that type of a situation. And when you compare them to the normal volunteer, it takes anywhere from 36 to 72 hours to do what the cirrhotic did in 8 to 10 hours. And it's very easy for our patients to go a prolonged amount of time when they're in bed and not eating. So it's critical to look at that. And where this data has been reinvented, I would say, is that the Italians have looked at it recently. They're back to the branch chains. And when you do visit in Italy, you see not all, but you see a fair number of their patients that are high up on the transplant list that are coming in with Doppler tubes. And the reason they're doing that is to feed them branch chains while they sleep at night. And it's had a remarkable effect over there. And I think it's a little bit easier. And what we can do here is the nighttime feedings. And that's what you can see up here, and I think that's what I'm sure you guys are doing that here is basically we have our patients take a can of whatever protein drink they can get in at bedtime, so they go through that at night without the empty stomach. Now, this is what some of the work that we initially put together, pilot work on this, and we thought we found something very important along the way, in that we looked at patients that were going through this muscle wasting process about 10 to 15 years ago. And we compared it to the folks, this is group 2, the folks that went through the standard of care. Typically what a patient would do that comes in with liver disease and is losing muscle and is full of ascites, we'll try and correct their nutrition. We'll give them diuretics to try and improve their ascites and encourage them to be more active. But we haven't necessarily gone after the hypogonadism, so to speak. And that's group 2. And what we quickly found, and this was what's puzzled us the most, why we had such a good result with this, is that when you treat these folks with a topical cream, their albumin start to go up. And we thought, with that, we were able to compare this data to actually what the Australians showed in the 70s with IM testosterone. The problem with IM testosterone, though, is that these folks have sarcopenia to begin with. There's not a lot of places to put a big muscle injection. It's still, I'm not saying it doesn't work, it still works if they have muscle. It's probably an easier thing to do for those folks, a shot once a month, that type of thing, or every 2 weeks. But it got us thinking is, why did all of the patients not recover in this regards? And that's where the next level of this has taken us. And what we've learned is that as you go through life, men in particular, we tend to slide off towards making more estrogen than testosterone. And that's what you're starting to see as well. What I would contend is that we're seeing in Major League Baseball, what we're seeing in the cyclists, is that they've been able to learn how to block this conversion over to estrogen with these OXO inhibitors. And as a result, drive up the testosterone levels. And tamoxifen is one that does that. But does that all work together, or is the malnutrition a big player with this? And are some of the medicines, for instance, the androgen receptor blockers, such as with aldactone, how big a player is that? And that's what we're currently looking at, is to try and find a parameter that we can use as a gold standard, not necessarily a gold standard, but one that we can use to see how much nutrition actually plays in slowing down the sarcopenia, then adding the androgen type of agents to see if we can not only stop the muscle wasting, but maybe improve it before they get into the transplant process. So the anti-androgens, as I mentioned, this is a big deal, and especially in the transgender surgery. There's a number of these medicines, and I think it's just an important part, and it's critical. What we all tend to think of is that ammonia or something else, and there's several other things probably that we do not know or have a good handle on, that are absorbed, that bypass the liver because the liver is now cirrhotic, that go on to the brain and cause the dysfunction. But we need to remember is that muscle plays a big role as well in breaking down ammonia. We know this because of that early cirrhotic that I mentioned that hasn't lost all of the muscle, doesn't have all of those HE-related problems that the patient that's gone through the next 2 phases of cirrhosis that does. So calorie counts, and we looked at this, submitted it for the fall. We'll see how we do it. This is where what I always say is that the way we're managing cirrhotic patients now is very different than it was 10 years ago. And 10 years ago is different than it was 5 years ago. We're slowly evolving. And this is a point that really changed my outlook on what we're doing for these folks, and it emphasizes how important nutrition is that if you look at the person who is starting to have this cloudiness of encephalopathy, that early stage of it, we call it subclinical encephalopathy. Some folks call it minimal. But when you start to look at that, our arguments 3, 4, 5 years ago were, should we treat those folks? Well, obviously you do, because you want to keep them employed. If they become unemployed, they lose their health insurance, and we know what happens then. So this is the group that we looked at, and typically that group will get about 80% of the calories in each day that they need. Well, the group that's similar to that is treated, that is given lactulose, will get in about 50 to 60% of the calories each day that they need. It's not because of the diarrhea, it's typically because of the bowel bloating, the distension of the bowel. They do not feel hungry. And then when you treat with rifaximin, you see about 80 to 90% on average are the calories that these patients will take in. So again, these are calories that these patients are not going to be able to recover. And it emphasizes the importance that maybe some of the things that we're doing to these patients, the beta blockers, the aldactone instead of amiloride, lactulose instead of rifaximin play a huge role in these patients. And a paper like this is published about every 10 years, and it tells us what we've just been talking about is to avoid calorie restrictions, protein restrictions, and activity restrictions. These patients need to eat, talk, and walk. They need to get through the day and not lose muscle and stay active. Well, that's all about quality of life and how important that is. Sometimes we forget these things. Now, HE, as we know, it's a complication that typically once the patients start to have it, it evolves and continues to worsen throughout their process with cirrhosis. And we see it in a vast number of patients. I would contend that cloudy part is probably seen in 80 to 90% of the patients, especially by the time they come to see us. And what I mean by that is that these patients have had a problem prior to visiting with us, and most of the time that's one of the issues. Well, what we typically classify encephalopathy into is overt and minimal or subclinical. I don't like the word minimal. The insurance companies tend to think of that as a minimal problem, and it's far from it. So I tend to jump on the bandwagon with the Europeans that subclinical is the right term. But the overt problem is, as I mentioned, as these patients progress through their levels of cirrhosis, the incidence of that increases. And the subclinical, as I mentioned, I think is a little bit higher than is being noted. If we went around the room and talked about how do you diagnose HE, you're going to get a difference of opinion. I remember presenting the rifaximin data to the FDA, and on the panels actually 4 neurologists, which neurology and hepatology tend to look at this in a little bit different mechanism in terms of the tests that we may use. But I think we would all agree is that there's a level of consciousness that changes in these folks, and it's supposed to be reversible. But there's data now coming out, and that we've all seen these patients, especially our accountants, our realtors, our bankers that have gone through the transplant process, but mentally they're not as sharp after transplant. And what we've all tended to do is blame Prograf for man's inhumanities to man as causing this issue. But we're starting to see is that even early on that we're not able to fully reverse the hepatic encephalopathy related issue. Some of it may be that we do not actually find the exact diagnosis or the exact entity that's causing it. And as you can see, this is the challenge that we have is when someone has hepatic encephalopathy, what caused it, so we can stop that and potentially try and get these folks back to their baseline. Well, is this the subclinical encephalopathy? A few of us will do that. I do that about every couple of weeks, not paying attention. A good far side. This is a test. You can do a lot of these tests. This is one that a number of us still use, the number connection. This is one I was taught as a fellow, and I remember my old chief saying, get 2 copies of it. As a fellow, you do one and have a patient do one and see who's more encephalopathic. This is the West Haven, and this is what we use on a daily basis on our patients. What's important about this, though, is that your patient is going to bounce anywhere from 0 to 1 and maybe even sneak into the level 2 at various parts of the day, depending upon the medicine, depending upon hydration, activity, these types of things. So you may see somebody in the day and they're a grade 0, but what it does is it emphasizes the importance of talking to the people who take care of these patients. And that includes in the hospital, it's the nursing staff. When you show up in the morning, how was the patient acting the last 24 hours while we weren't there? It's a critical question. The other one is the family. The family is the best ammonia test. We tend to get ammonia tests on a lot of these folks and use that as our scale, but actually talking to the family will tell you how these folks are interacting with the family. Also, are they able to get through work? Are they able to get through their daily chores? These types of things. And again, it's because these patients, we see them for such a short time frame, and they're in one of these grades only for a very short period. The minimal or subclinical, as I mentioned, tends to go on to cause the overt related problem, and that's what we want to stop. Where we are today and what we do I definitely feel will be very different in 5 to 10 years. I'm hoping 5 years. What we typically do is someone has an overt event, we then start to treat most of these patients instead of trying to prevent that overt issue. And why I say prevent is because you saw what the 1-year survival is. It's terrible in this group. It's less than 50%. But what we do is we get them into remission and try and keep them in remission. And that's what the medicines that we have right now are geared at doing. Well, the treatment options that we have, there are 3 FDA approved. There's lactulose, neomycin, and rifaximin, and we'll talk about those. But basically what we're doing is we're either trying to change the gut flora or lower the nitrogenous base. Manipulation of the splanchnic circulation. This is one I always found of interest because we had a patient that recently went through a colectomy and had some HE issues prior to it. But in Miami, we used to be fortunate enough to have Sheila Sherlock, Dame Sheila Sherlock, would come and visit every 6 months. And she's credited with Dr. Schiff's father and a gentleman from Germany as being the 3 founders of liver disease, 60, 70 years ago. And in the 70s, she had done a study of over 100 patients where they did colectomies. And these patients that are so sick that you take a mole off of them, they bleed to death. And they did colectomies on them. Half of them died, but the half that lived did not have any more HE. So that's where some of these circulation-related issues come up. Obviously, that's not something we get through the IRB today. But the strategy, again, is here, and we're trying to stop that. And what we see is with lactulose, and it's adjusted on a daily basis. So as you heard me say, we have confused patients that have some level of encephalopathy, and we're going to coach them on how to daily and every 8 hours adjust their medicine that they're taking, that they're supposed to take it so that they have 2 to 3 soft bowel movements per day. Soft, okay? That will come into play in a minute. Its efficacy is not well documented. We know that. It was in 3 placebo-controlled trials in the 60s and 70s. The FDA had, from the minutes, they do not exist from when it was approved. So again, this was over 30 years ago. We do use it. It's a frontline agent in terms of, especially when patients come into the hospital. But what we're seeing is less and less of it being used, and a lot of it is because of a variety of quality of life issues. But in our center anyways, it's more based on the inability to properly give our patients nutrition. And I always say, I have 2 young girls, and they say they don't do this flatulent stuff. And I always say, because if you're not on lactulose, that should be about 100%, not 74% right here on the, I don't know if the arrows, right here. That should be about 100%. My little girls say that doesn't exist. But nonetheless, if you're on this drug, you're having diarrhea, flatulence, abdominal pain, and distension. And the distension is what is a big deal in the nutrition experts. So the oral antibiotics, neomycin, if you're using that, we still see some folks doing that. It's about 1% of the folks in the country that use it. We have tended to use it in individuals that tend to be resistant to rifaximin, lactulose, that may need a 3rd agent. But most of those folks are so close to either getting transplanted or dying that it's not used for very, very long. And then metronidazole. That's a medicine that we tended to use about 10 years ago. It works very well with this. The problem is that folks do not eat on it. I actually was on it once, had gotten a bird dog from the Dakotas that came with Giardia. And me being the dad, I got to take care of the dog while he got used to the house, and picked it up and was on Flagyl for 2 weeks, and it was a great weight loss drug. So, and again, we do not want our patients going through that. So rifaximin, or Xifaxan 550, is a medicine. This is just very quickly the trial that got it approved recently by the FDA. It was a double-blind, placebo-controlled, multinational. It was U.S., Canada, and Russia. And it was given 2 pills, or 1 pill twice a day. And the important part of this trial, though, is that these were patients that we were studying that had at least 2 episodes of HE. They had 2 documented episodes And for the most part, they were likely admitted to the hospital and treated, stabilized, and brought back down to a baseline of 0 or 1. And what that means is back then we were treating everyone with lactulose in that setting. Some of us were starting to get into rifaximin and use it for. But so what happened in this trial is that you had the two arms. You had the folks, and 91% of both arms actually fit this way, is that 91% were on rifaximin and lactulose, or they were on lactulose and placebo. So it wasn't a true head-to-head, but you can't really do a head-to-head in this group. You can't stabilize them and then stop their HE management. Ethically, you're going to get into problems there. Demographically, they were very similar. The daily lactulose that was used, was it used correctly? Yes, and this is not done, at least in my practice. I don't call the patients to ask them how they're stooling, but they actually had to do this. We had to do this twice a week. One of our assistants would. And there was actually a lucky individual in the family that kept a stool diary, that every time their loved one went, they had to run over to the toilet and look at it. I said, that's a real loved one. But nonetheless, so we were very comfortable knowing that they were taking that medicine correctly. So what happened out of that is that we found that there was a 58% reduction in these events. So, and what I mean by that is, you saw earlier that we wait for the avert event, and then we try to keep these folks in remission. This drug was able to do that in almost 60%. And most importantly, pharmacoeconomically, it was able to reduce hospitalizations in half. And that's becoming a big issue. It's going to be very important for us to, one, keep these folks out of the hospital, and when they do come into the hospital, to shorten their stay. And there's a lot of data coming out right now that shows that you can markedly cut that hospitalization stay down by treating them preemptively with that. So in conclusion with this, on hepatic encephalopathy, the management of our cirrhotics continues to evolve. Nutrition, I think, is one of the most important parts of what we do for these patients or don't do. And the reason I say that we don't do is I showed you medicines that we give these patients that actually cause them not to want to eat. We actually give these patients medicines that make them inactive. We give them medicines that block their ability to stop the muscle wasting and potentially redevelop it. So endocrine and nutrition, which is most important? That's what I hope we can figure out in the next 5 to 10 years. What I think we're going to find is that they're both equally as important. The potential complications and how to manage those. We're going to see, as hepatologists and gastroenterologists, we're getting involved a lot sooner in these patients. We're trying to prevent the overt event. And I think that's critical with these folks is the cardiologists, I think, do a fantastic job at trying to prevent that MI. They get on that cholesterol right away. We know that. But yet we're not doing that, so to speak, in the hepatology world right now, trying to prevent what I would call as almost the myocardial infarction in a cirrhotic patient. And the minimal, as we know, it markedly decreases their quality of life. It behooves us to keep these folks employed. If they become employed and lose their health insurance, and we see this time and time again, and when I travel around, you hear of these stories all of the time about these individuals that are on the list that you have to delist because they've lost their health insurance. And the clinical efficacy of what we showed, why rifaximin is so important, is that it actually keeps people in remission. Once that snowball has developed, that the Michigan folks that recently showed us that we all see and we all live in, is that these folks continue to get readmitted. This drug is actually able to keep these folks out of the hospital, and with a 50% reduction in hospitalizations. So I think that's it, and make it in time. Good.
Great talk, Guy. Any questions for Dr. Neff?
So I'm a nephrologist. I think for people with end-stage renal disease, there are a lot of similarities in
Very much.
complexes. We don't have variceal bleeding, but we certainly have fatigue, sarcopenia, loss of appetite, that sort of thing. In the renal literature, there is a lot of emphasis on looking at the roles of chronic inflammation and insulin resistance in as contributory factors for sarcopenia. And then in terms of the encephalopathy, an increase in the absorption and decreased excretion of other substances coming from the colon that could be contributing to the uremic encephalopathy. So I was wondering, if these have been looked into.
Well, actually, you have the world's expert in it standing next to me. And in all honesty, though, one of the things I did at Cincinnati, and we're starting it up in Florida, is we had a thing called the Midwest Liver Forum. And I always tried to get Craig to come up because you hit the nail on the head there. And as we had talked earlier about the mucosal defects in the bowel tend to allow these things to be absorbed. And that's our first area of resistance in terms of preventing these types of problems from developing. The biggest challenge, I would say, is there's still a lot of these items that get absorbed that we're still trying to figure out. Is that a fair way to put it? That, it's ammonia and cytokines and a whole lot of other things.
Yeah, so I think in the renal literature, they focused on some things a little bit different than us. So especially tryptophan metabolites are a big thing there. But again, they're all gut derived, and so lactulose does something, Xifaxan does something, but even probiotics. So anything that'll stabilize the gut barrier function, keep bowel movements going in the right direction, and decrease absorption of toxins is going to be a beneficial thing for a host of disease processes. And so at DDW, where we both came back from, probably the hottest topic there by far was the gut microbiome and the gut-liver axis. So I think you're exactly right.
I'm a palliative care physician. I just love your lecture. Secretly, you seem to be a palliative care physician. I didn't want to say that.
Coming out of the closet, but yeah.
One of the things I notice is patients that I work with is you take any advanced disease and you're going to see malnutrition again. By the time you get to that point, it's almost impossible to do anything to address that. So I would put it to you that we really need to be focusing on nutrition way earlier for all our patients, so we just don't get to this point.
Yeah, one of the great joys.
Repeat that. So.
Yeah, the question is about trying to get nutrition involved a lot sooner, and I wholeheartedly agree. And we do so much to these individuals, and I only spent a brief amount of time on that, and that's almost an entire hour of what we actually do to these patients that makes you scratch your head that we've learned over time. And again, I think that's what I took home listening Dr. McLean the first time for about 4 or 5 years ago at AASLD about how important this nutrition stuff is for these patients. And I always say one of the great loves that we all have in life is eating, and we often talk about, what restaurant we've gone to and this and that, and that's removed from these folks' quality of life. And for all intents and purposes, a cirrhotic has 2 outcomes. They're either going to get transplanted, they're going to be one of those lucky few, or they're going to die. And what we do for those folks as they go down that road and we can't do it for all of them, but it's a major impact, not just on the patient, but the family. If you can improve their quality of life in the patient, you're improving the quality of life in the family, and that's huge. I think it's the nutrition part, and we miss the boat on that a lot. I know I did as a fellow and a young attending.
And I'd say it's amazing how quick muscle mass comes back when you get a new liver, when you think.
Yeah. It can, especially, I think the PSC population is the best group. They tend to come in and look like our gentleman there, young, and then 2-3 years later, you've got to start slowing them down on what they're eating, and.
So the picture the guy showed of my patient, that was a patient of mine from Minnesota, and he was actually a young guy, and we had a clinical research center there. So I told him if he participated in every clinical trial I did, why I'd personally take care of him and see if I could help him out. So that was when he was basically at his nadir. He ended up getting a Levine shunt to redirect his ascites. He stopped drinking, and when I left Minnesota in 1982, he was a hard guy to get a hold of because he didn't have a phone number because of debt collectors. But I called his mom and said, can I talk to Roger? And she said, oh, I know he'd love to talk to you, but he's out skydiving now. So he had put muscle mass back on and looked fantastic. So that shows you how, if your disease process gets better, why you can actually change your muscle mass too. Steve?
So in the study where the albumin levels rose and testosterone was administered, and there were many other components to the treatment protocol there. Have there been studies which sort of just looked at whether testosterone is included or absent from the treatment protocol? But mechanistically, you wouldn't think of testosterone regulating albumin.
No, and that's,
antigen response to heat, so.
You're exactly right. And that's when we go back and we look at that, we're kicking ourselves for not being more attuned to the nutrition component of that. Because we have revisited that, and that was more pilot work trying to get a grant. And, you know, in the various levels of cirrhotics, there's a difference in response too. And I think that's the first part is to look at these folks early on in cirrhosis and see how much they'll recover. You know, when you look at the first line of the package insert of any of these androgen agents, it says don't use in someone with liver disease. And, or first or second line. The first line may be cancer, and then the second line is you may cause cholestasis and this and that. But these things tend to be safe actually in these patients. And they need further development. There just really isn't a lot of energy. And what I was telling Dr. McLean prior to leaving Cincinnati, the grant I had submitted to the NIH had the lowest score at the University of Cincinnati in the medicine department, and the NIH wasn't going to fund it because they said there's not an interest in muscle wasting in cirrhotics. Yet, as I showed you, fatigue, they all show up with fatigue, and fatigue is associated with a number of things, not eating well, not moving well, and all of that starts some level of muscle wasting to occur. So.
Unfortunately, my patients that have this illness, the vast majority are uninsured and are never going to be a liver transplant, or they're going to be able to afford right accident, etc. But one of my questions is, when you talk about spironolactone, I have forgotten any physiology other than the potassium sparing component for ascites. Can we not just use loop diuretics with appropriate potassium replacement and get rid of spironolactone?
We use a miloride for it, and the big catch in that is in the at least what I remember is in the 90s. One of the reasons we would only use a miloride is when they got the breast tenderness from the aldactone, and the belief of it was a cost issue. One of them was a little bit cheaper, and it may work a little bit better.
But it's still just with the potassium sparing.
Right. We'll use that with Lasix in that setting. We still use the Lasix in that. But you know, and again, when we first looked at that data, we had those folks on aldactone. You know, they weren't eating well, so we had all of these things that we're now going back and looking at to see can we get that testosterone not in the Major League Baseball level, but somewhere in between where they are now and in that level. So,
Guy, you mentioned driving, so this is an issue that we deal with all the time. So, what do you tell your patients?
Well, you know, we have EPIC, so a paragraph dumps in, and we've also talked with these patients about it. They can't. And I think when you look at this type of a setting, the neurologist, when they talk about seizure disorders, that, you know, these folks have limitations in what they can do. And this is a big life changer for these folks, is when you take driving away or operating machinery. And I have a whole, you know, I deleted a lot of it, but it talks about that various issue, how important it is that these folks are watched carefully. But it also emphasizes we need to get these folks sooner. We need to get them before they get into that subclinical HE issue and start treating them. And that's why when I always get the question, do you treat minimal or subclinical HE? I'm like, by all means. I mean, not only that, but I think we ought to do what the cardiologists did so well in the 80s and 90s, getting into that pre-lipid era and trying to prevent the initial MI. That's where I'm hoping in the next 5-10 years we get to, that we're preventing that first overt event.
So certainly in our hepatitis C clinic at the VA, why it seems like half of our patients are long-distance truck drivers, and if you've ever looked at them, you figure they either have NASH or hepatitis C, so it's scary sometimes what's on the road.
It is. And one thing I would add, and I know it shouldn't play into medicine, but JDs are starting to show up in the HE literature, the hepatic encephalopathy literature. My drive to work every day is through the crosstown in Tampa, and it's a tollway, and every other sign advertisement is an attorney wanting to know if you had any related issues. So someone in America is going to get sued over this. And we've all taken care of people. I remember in Miami, we had an American Airlines pilot that had encephalopathy. And luckily, they fly with somebody, but the truck driver that doesn't. And I think that also emphasizes why, if you can get these folks and keep them functionally working, and why I think in these truck drivers, why rifaximin is such a good choice. Lactulose, we looked at about 200 plus of the patients that were sent to us at Cincinnati before I left, and asked them what their thoughts were about lactulose, some of the experiences they were having, and a third of them admitted to public encopresis. They had had a bowel movement in public because the lactulose had kicked in. And if you need to find, what I always say is, if you need to know where a bathroom is, ask somebody that's on lactulose, because they know where all of them are in a building. Because when that stuff hits, it's going. So it's a real game changer in your quality of life.
With that pleasant thought, thank you very much, Guy.